Here, we are going to talk about the anticoagulant. Anticoagulant we use to prevent the blood clotting. The most common and popular anticoagulant we use heparin, warfarin, or coumadin. Heparin is an injectable form and prevent the conversion of prothrombin to the thrombin. And anticoagulant, as I told you, they prevent extension and formation of clot by inhibiting the factor in the clotting cascade and decreasing the blood coagulabilities. Anticoagulants are administered when there is evidence of or likelihood of clot formation. So what are the medical conditions patient chance to develop the blood clot? Example are myocardial infarction, unstable angina, atrial fibrillation, deep vein thrombosis, pulmonary embolism, and presence of mechanical heart valves. So if any patient have an atherosclerotic change occur because of accumulate of bad cholesterol, they have a chance to develop blood clot formation. If any patient is immobilized for a long time, just imagine a patient came after the major surgical operation, then they are immobilized. So they have a chance to develop deep vein thrombosis, and deep vein thrombosis, blood clot formation and clot the traveling in the circulation. And when they fall in microcirculation like pulmonary system or cerebral system, they start to formation the clot. So we have to have something prevent the blood clotting and prevent the conversion of prothrombin to thrombin and save the life. So in this picture, you can see this is the blood vessel and clot formation, right? Aggregation of blood cell. Here, the list of anticoagulant name. Some of the anticoagulant oral and some are parenteral or injectable. Most common anticoagulant orally we use warfarin or dabigatran, and parenterally most popular one is heparin injectable or heparin sodium, enoxaparin, right? Or here is said deltraparin, right? Another is enoxaparin, other name is called Lovenox, right? And warfarin, other name is called coumadin. So this is the most common anticoagulant frequently we use, right? So when our patient need anticoagulant, as a healthcare provider, it is very important to educate our patient. We call nursing implication or intervention, right? So here showing the anticoagulant pathway, or this is the cascade pathway where the bleeding, if any bleeding occur, blood can clot formation and stop the bleeding. But here we are talking anticoagulant, how they work, right? So first of all, orally and parenteral form. you see different factor convert each other. During the conversion, the anticoagulant blocks the pathway. Like here, example, dabigatran stop the factor 2A and they prevent fibrinogen to fibrin. So in different pathway, the anticoagulant work and stoppages the clot formation. Here showing the substance to avoid with anticoagulant. So if your patient need to take anticoagulant, you educate them, do not take this substance, this list of substance with anticoagulant, right? So if my patient take anticoagulant, it is important routine monitor for prothrombin time, INR. Also, it is important to educate, tell them to avoid over-the-counter medication and herbal product. Particularly during heparin, it is important to monitor PTT and INR. If your patient take coumadin, it is important to monitor PT and INR. And also, it is very important if my patient take warfarin or enoxaparin, important to monitor complete blood count because patient at the risk for heparin-induced thrombocytopenia. We educate patient to monitor for the sign of bleeding, particularly if our patient take coumadin. It is good to limit cabbage and green leafy vegetables. Also, it is good to avoid caffeine and ethyl alcohol. And here showing the medication list good to avoid, like allopurinol. Allopurinol we use for gout. Cimetidine, it is for peptic ulcer disease medication. Cimetidine, also steroid like corticosteroid. Green leafy vegetables or other foods which is high in vitamin K. Non-steroidal anti-inflammatory drugs, better to avoid. Oral hypoglycemic agents, phenytoin, anticonvulsant medication, good to avoid. Or salicylate, sulfonamide, also herbs like ginkgo biloba or ginseng, good to avoid. Anticoagulants are contraindicated with active bleeding. So if my patient have active bleeding, tell them not to take, except for DIC, disseminated intravascular coagulation, bleeding disorder or blood dyschriasis, active ulcer, liver problem, kidney disease, and also if patient has an active hemorrhage or brain injuries. What are the common side or adverse effect of anticoagulant? The common side effect, patient chance to develop bleeding. So if patient chance to develop bleeding, it is important to remember what are the signs that indicate the bleeding. Patient chance to develop thrombocytopenia, means platelet number go down, nausea, also increase the liver function test or diarrhea. And some patients develop the hemorrhage, right? Hemorrhage means active bleeding. Or patient chance to develop hematuria means urine mixed with blood, or epistaxis, it means nose bleeding, ecchymosis, bleeding gum, thrombocytopenia. Sometimes we call heparin-induced thrombocytopenia, more common in enoxaphene can cause it, or hypotension. Now we are going to talk about the heparin particularly. It is called heparin sodium. Heparin prevents the thrombin from converting the fibrinogen to the fibrin. Heparin prevents thromboembolism. So this is the blood clot formation, right? So they also embolus formation, emboli, we call emboli. The therapeutic dose does not dissolve the clot, but prevent the new thrombus formation. What next? Blood level. Normal activated partial thromboplastin time. So if my patient take the heparin, what are the important information as a healthcare you have to know? So normal activated partial thromboplastin time. It is normally 30 to 40 seconds. In the most laboratories values. Now, to maintain the therapeutic level of anticoagulant, when the client is receiving a continuous infusion of heparin, the partial activated thrombin should be 1.5 to 2.5 times the normal values. And some agencies use two different protocols. A high-intensity protocol, such as for acute coronary syndrome, and low-intensity protocol for venous thromboembolism prophylaxis, and also the dose and recommended PTT range are slightly different for different protocols. So what we have to remember from here, the activated partial thromboplastin time should be 30 to 40 seconds. But if your patient undertake the anticoagulant, and if you check the partial prothrombin time, it should be 1.5 to 2.5 times normal values, and nothing abnormal it is. What next? Blood level continue. So activated partial thromboplastin time therapy should be measured every 4 to 6 hours during initiate the continuous infusion therapy, or until that client has been therapeutic for specific time of specific time frame, or when daily per agency policies. If the activated partial thromboplastin time is too long or longer than 90 seconds, the dose should be lowered. So what are the normal PTT? 30 to 40 seconds. So if it is more than longer, we have to change the dose. If PTT is too short, less than 60 seconds, that dose should be increased. So while my patient under anticoagulation anticoagulant therapy, what we could monitor. So first of all, we have to monitor the PTT, means here activated partial thromboplastin time. Also, we could monitor the platelet count. Why we could monitor the platelet count? Because anticoagulant induce thrombocytopenia. So we could monitor. And here also instruct the client regarding measure to prevent the bleeding. If it is overdose occur, we need antidote. And antidote we use, it is called protamine sulfate. Right? It is the different than warfarin. So keep it note, if patient has a heparin overdose, we use protamine sulfate, right? And heparin sulfate, it is the mucopolysaccharide. Usually we use heparin parental, but warfarin we use orally. And heparin immediate work, but warfarin delay type work. And duration of time heparin is shorter, but warfarin is longer. So what next? Next here, and it's also I said for warfarin we use the vitamin K. When administering heparin subcutaneously, injection into the abdomen with 5/8 inches, means 60 millimeter needle. And continuous infusion must be run on infusion pump to ensure a precise rate of delivery. Now let me talk about the warfarin. Warfarin suppresses the coagulation by action agent and antagonist of vitamin K by inhibiting 4 dependent clotting factors. So factor 10, 11, 8, and 2. This 4 factor is dependent on vitamin K. So warfarin prolongs the clotting time and is monitored by prothrombin time and also INR. It is used for long-term anticoagulant and is used mainly to prevent the thromboembolic conditions such as thrombophlebitis, pulmonary embolism, embolism formation caused by atrial fibrillation, thrombosis, myocardial infarction, or heart valve damage. So normal PT is 11 to 12.5 seconds. Right? And warfarin sodium prolong the PT. And also therapeutic range should be 1.5 to 2 times the control values. So international normalized ratio, shortly called INR, the normal INR 0.81 to 1.2. And INR is determined by multiplying observed PT ratio by correction factor specific to a particular thromboplastin preparation used in the testing. The treatment goal of warfarin sodium is to raise the INR to an appropriate values. Let me talk something more about the INR. So the INR of 2 to 3 appropriate for the standard warfarin therapy, and INR of 3 to 4.5 is appropriate for high-dose warfarin therapy. If the PT value is longer than 30 seconds, the INR is greater than 3 in a client receiving standard warfarin therapy, and it is indicate bleeding precursor. If the INR is below the recommended range, the warfarin sodium should be increased. Client may sometimes be prescribed bridge therapy where the heparin sodium is used concurrently with warfarin sodium until INR reach to the recommended range. Once this occurs, heparin discontinue. Why? The reason being, heparin onset of work is immediate, but warfarin is delayed. In emergency, heparin can work rapidly, and when you start the warfarin, they take time to start work. When warfarin start work, you withdraw or stop the heparin. And also heparin we use parentally, but warfarin we could use orally. And as I told you, heparin rapid onset of action, but warfarin slow onset. It takes several days to work. And next here, so when our patient take warfarin or heparin, and bleeding is a common sign. I mean, it's called adverse effect. So if patient develop the bleeding, we always stop and inform the healthcare provider. So what are the signs that indicate patient have a bleeding, right? So in this picture showing the bleeding precursor, easy to remember, RANDI, RANDI. R means razor, electric razor. So it is good to use the electric razor during the shave, or no aspirin at all. So aspirin and heparin or warfarin can increase the chance of bleeding. And use the needle small gauge, decrease the needle streak. Also, it is good to protect injuries. And also, when you observe what are the signs like hematuria or melena. So blood mixed with urine, hematuria. Blood mixed with stool, melena. Sometimes gum bleeding or gingival bleeding, nosebleed or bruising here. No aspirin, limit the needle speed. Also, implementation when using anticoagulant, or if patient has a liver problem, if platelet number is go down 150,000, or if the patient has a history of hemophilia, so it is important, need to follow the precursor. Here showing a picture vitamin K rich foods like avocado, green apple, green grapes, then kiwi, lemon, green peas, broccoli, and also beans, cabbage, right? They contain a good source of vitamin K. So what are the intervention if patient need to take warfarin? We monitor PT and INR, observe for the bleeding gum, bruising, or nosebleed. Hematuria, hematemesis, occult blood in the stool, and also PTTI. Instruct the client regarding the diet and measure to prevent the bleeding. The antidote are vitamin K, or other name is called phytomenadione. So phytomenadione means actually it is the source of vitamin K from plants origin. Anticoagulant, that is called dabigatran. So dabigatran work through the direct inhibition of thrombin prevention, the conversion of fibrinogen into the fibrin, and activation of factor 13, right? And the current approved use is for clot prevention associated with non-valvular atrial fibrillation. It is administered in a fixed dose twice daily. Blood level, no blood test is required. Intervention, same as warfarin. Other is called rivaroxaban, works through inhibition factor 10A. And approved use include for the clot prevention associated with non-valvular atrial fibrillation and after knee or hip replacement. Blood level, no blood testing required. And here, thrombolytic medication. And this medication, thrombolytic medication, activate plasminogen or plasmin generate, plasminogen generate plasmin. So they activate the plasminogen, right? And thrombolytic medication are used early in the course of myocardial infarction to restore the blood flow and limit myocardial damage and prevent the left ventricle function that stop the patient death. And thrombolytics are also used in arterial thrombosis, deep vein thrombosis, occluded shunt, or catheter, or pulmonary embolism. So you see, this is the picture. This is the thrombus formation, right? And blood is going here, and this is the thrombus, venous thrombosis. So if you want to prevent, we use the thrombolytic medication, or we use the antiplatelet medication. So now here the example of thrombolytic drugs, we use the Antiplatelet, or right. So contraindication of thrombolytic medication: activate internal bleeding, or history of hemorrhage or shock, also intracranial problem include trauma. So if your patient have this problem, it is good not to use thrombolytic medication. If patient has a history of thoracic, pelvic, or abdominal surgery in the previous 10 days, it is good not to give them thrombolytic medication. Or history of renal disease, history of liver disease, or uncontrolled hypertension, recently required prolonged cardiopulmonary resuscitation or known allergy to the specific product or any of its preservatives. What are the common side or adverse effect of thrombolytic agents? Bleeding, dysrhythmias, or allergic reaction. So bleeding is common in anticoagulant. Bleeding is common side effect of thrombolytic medication, and bleeding is a common side effect of antiplatelet medication like clopidogrel or triclopyrin. Common side effect. Intervention determined activated partial thromboplastin time or PT, fibrinogen level, hematocrit, or platelet count. Good to monitor vital sign and assessment the pulses, monitor for bleeding, and check all excretion for opal blood, or monitor for neurological change such as speed, lethargy, confusion, or hemiparesis. And what are the intervention therapies or intervention we could do if our patient have a medication thrombolytics? We monitor for hypotension and tachycardia. Avoid injection and unnecessary venipuncture if possible. Apply direct pressure over puncture site for 20 to 30 minutes. Also handle the client as little as possible when removed. And also handle the client as little as possible when moving. Instruct the client to use an electric razor for shaving and to brush the teeth. Withhold the medication if bleeding develops or notify the healthcare provider. And what are the antidote we use? And also it is important if overdose occur, we use the antidote, right? And amino caproic acid we use as an antidote. Use only in acute or life-threatening condition. So our first line is anticoagulant to prevent the clotting, or we use the antiplatelet for prevention the clot formation. And if nothing can work, we go for use thrombolytic medication, particularly in acute condition, life-threatening condition. And bleeding is the primary concern for a client who takes an anticoagulant, thrombolytic, or antiplatelet medication. Now let me talk about antiplatelet medication. Antiplatelet we use to prevent the clot formation by blocking the platelet aggregation. The common drugs we use clopidogrel, triclopyrin, or dipyridamole, right? So antiplatelet medication inhibits the aggregation of platelet in the clotting process, thereby prolong the bleeding time. Antiplatelet medication may be used with anticoagulant and used in prophylaxis of long-term complications following myocardial infarction, coronary revascularization, stent, and stroke. These medications are contraindicated in those with bleeding disorder and known sensitivities. Here the drug list, we use antiplatelet, and most common one we use acetylsalicylic acid or clopidogrel or silostazole, or we use dipyridamole triclopyridine. And parentally, we use the aveximab. What next? Next, the common side and adverse effect. Bruising, hematuria, gastrointestinal bleeding, and cherry stool. So blood mixed with stool look like blackening. So what are the other side effects? As I told you, common side effect is bleeding. And we remember what are the common sign of bleeding that indicate patient have an active blood loss. Sometimes patients have a common side effect nausea, stomach pain, rash or itching. Also, upset stomach, diarrhea, and headache. So nursing implementation or intervention is important. If my patient take antiplatelet, it is good to avoid, if allergic to aspirin, ibuprofen or naproxen. We hold 7 to 10 days before any major surgical operation, or we should use with caution during activating requiring alertness such as driving a car. We educate our patient for monitoring for sign of bleeding, or do not use any other over-the-counter medication, or it is good to avoid use of aspirin, salicylate, or NSAID while taking this medication. Then also it is good to antiplatelet medication avoid in pregnancies. Right? So what are the intervention? Let me recap it. Determine the sensitivity before administration of antiplatelet, before administration of clopidogrel, triclopyridine, or dipyridamole. We monitor the vital sign, instruct the client to take medication with food. If gastrointestinal upset occur, monitor the bleeding time, instruct the client to monitor for side and adverse effect, and in measure to prevent the bleeding.